Okay, welcome to the deep dive. We're about to dive headfirst into a topic that is, well, incredibly common, often frustratingly misunderstood, and it reveals some truly mind-bending things about how our brains actually work.
Hmm.
We're talking about functional neurological disorder, or FND.
Hmm.
And for this deep dive, we've pulled together a really rich stack of sources. We've drawn on insights from leaders in the field like Professor John Stone, Dr. Jeffrey Staub, and neurological physiotherapist Paula Gardner, who've done foundational work in understanding and treating FND.
Right.
But critically, we've also listened closely to the experiences of someone living with the condition, Hamish, whose perspective really anchors the science in lived reality.
Yeah, that's so important. Our mission today is to cut through the noise,
Hmm.
get really clear on what FND is, understand its difficult history, and perhaps most importantly, grasp why understanding it correctly is so vital. We are absolutely dismantling the harmful, outdated notion that it's all in your head. Get ready for some surprising insights into the brain's wiring and the very real potential for people to recover. Let's unpack this.
So, to start, the fundamental shift in understanding FND is recognizing it as a disorder of brain function, not structure.
And why is that distinction so crucial? What do we mean by structure versus function?
Well, when doctors talk about a structural neurological problem, they mean something you can literally see if you look inside the brain, perhaps damage from a stroke or
A tumor.
a tumor, exactly, or the lesions you'd see in multiple sclerosis. The physical machinery, the hardware of the brain, is damaged.
Okay, got it. Like something is physically broken or missing.
Precisely. With FND, the hardware seems intact. The scans, the physical structure look normal.
Uh-uh.
The problem is with the software, how the brain is running its programs, how different parts are communicating and coordinating. That's a really clear way to put it. It's like the brain's operating system has a glitch, not that the computer itself is smashed. I think one of the sources used a great analogy too, right?
Yes, Paula Gardner used the image of a piano. With a structural problem, the piano might have broken strings or cracked keys.
Right.
But with FND, the piano is whole, all the keys are there, the strings are intact, but it's horribly out of tune.
Ah,
The instrument can work perfectly, but the output is distorted because the system for playing it is off.
that's perfect. And I know this point can't be stressed enough because of the history. FND is real. It is happening in the brain.
Absolutely.
Right.
It's vital to reiterate this because of decades of misunderstanding. F&D is not non-organic.
Mhm.
That's a completely nonsensical term when applied to a human being.
Right.
And it is definitely not someone faking or intentionally causing their symptoms.
Right.
It's an involuntary, genuine neurological disorder rooted in brain function.
Yeah.
This distinction isn't just medical jargon. It's absolutely fundamental to how patients are seen, treated, and how they can begin to recover.
It's almost hard to believe that something so real could be so widely misunderstood, especially since it's not exactly a new thing, is it?
Not at all, no. It was described way back in the 19th century, although often, unfortunately, framed using terms like hysteria, which immediately pathologized it, particularly in women.
Right, that loaded term. And then it showed up undeniably in a very different population, didn't it?
Yes. World War I saw a huge number of soldiers developing symptoms like tremors, paralysis, and speech problems following the intense physical and psychological trauma of trench warfare.
Shell shock.
It was recognized as shell shock then.
Yeah. So it was clearly a response to overwhelming circumstances impacting the nervous system, but then the understanding seemed to detour a bit.
Precisely. For much of the 20th century, particularly influenced by figures like Freud, the dominant model became conversion disorder, focusing almost exclusively on the idea that unconscious psychological stress was being converted into physical symptoms.
And that is where the harm really set in for patients. That idea led directly to people being told, essentially, there's nothing wrong with you, or
Just all in your head.
it's all in your head, in that dismissive way, because their scans and tests were normal. You hear stories, including from Hamish, about the pain and isolation of that experience.
It's a devastating legacy. A survey mentioned in the sources highlighted how commonly people with FND feel disrespected or doubted by medical professionals,
Wow.
a feeling reported far more frequently than by patients with conditions like MS or epilepsy.
Yeah, it's telling.
But thankfully, the pendulum is swinging back now towards recognizing FND as a disorder fundamentally rooted in how the brain works, bridging neurology and psychiatry.
Okay, so it's not just diagnosed because all the tests are normal if it's not a diagnosis of exclusion anymore. How is it diagnosed now? What are clinicians actually looking for?
It's moved to being a diagnosis of inclusion. Clinicians look for specific, positive clinical signs during a neurological examination that are characteristic of FND.
Positive signs.
Yes, these signs don't just rule out other things.
Uh,
They actively point to the nature of the functional problem.
Okay, this is where it gets really interesting. What are some of these positive signs that tell a clinician, this looks like FND?
Well, a classic example is functional limb weakness. We heard about Rachel, who experienced sudden weakness similar to a stroke.
Uh-huh.
When examined, a key sign doctors look for is something called the hip abductor sign.
Explain that. What does it involve?
Okay, imagine someone has significant weakness in one leg. They can't voluntarily move it well.
Yeah.
But when you ask them to push outwards with their other, good leg against resistance,
Yeah.
you'll often see the weak leg on the opposite side automatically activate with normal or even stronger power.
Wow. So the muscle and nerve pathway can work perfectly fine, but only when the brain isn't trying to consciously command it.
Exactly. It's compelling evidence that the potential for normal function is still there. The issue isn't a damaged muscle or nerve. It's how the brain's voluntary control system is accessing or commanding that limb. For patients, seeing this happen can be incredibly powerful. A real light bulb moment that shows them their leg can work, and the problem is the brain's signaling.
That perfectly illustrates the function versus structure idea. What are other signs?
Functional dystonia is another. This is where a limb off a hand or foot gets stuck in an abnormal, sometimes painful posture.
Okay.
Picture a foot twisted severely inwards or frozen in an odd, contorted position. A fascinating thing here is that patients with functional dystonia in their foot might feel like their foot is in a normal, straight position when their eyes are closed,
Even though it's visibly bent.
even though it's visibly bent. Yeah.
How on earth does that happen?
It points to a problem with the brain's internal map or prediction of where the limb is in space.
Ah.
The visual information or feedback from the twisted limb isn't correctly integrated with the brain's internal sense of the body's position.
And functional seizures, how are they different from epilepsy?
They have distinct characteristics clinicians look for. While they can look very dramatic, they often involve eyes being closed, unlike epilepsy, specific movement patterns that don't match epileptic seizures, and different breathing patterns.
So it's not just ruling out epilepsy.
No, it's identifying the positive features of the attack that are characteristic of FND.
It all comes back to this idea of brain function being altered. How does modern neuroscience explain why the brain might get stuck in these problematic patterns?
It relates to our evolved understanding of the brain. We used to think of the brain as primarily a reactive system, just receiving information from the senses and reacting.
Right. Input output.
Kind of. But the modern view, supported by significant research, is that the brain is fundamentally a predictive organ. It's constantly generating predictions about the world and our body's state, using incoming sensory data to update and refine those predictions.
Like that green needle brainstorm audio illusion. The same sound clip, but what you expect to hear changes what your brain perceives.
Precisely. That's a small, fun example of how our attention and expectation, which are part of the brain's predictive process, can dramatically shape our perception. It gives you a little window into the power of brain prediction.
So in FND, the brain's predictions go awry, sort of.
That's a leading hypothesis, yes.
Yeah.
The brain might get stuck in predicting a symptom, predicting weakness, tremor, or pain, even when there's no underlying structural reason for it.
And that faulty prediction overrides the normal signals.
It seems it can, yeah. In functional weakness, for instance, the brain might be predicting that the limb isn't connected or isn't safe to move, making conscious, voluntary command incredibly difficult.
Interesting. Almost the opposite of phantom limb.
It's almost the conceptual opposite of phantom limb syndrome, where the brain predicts a limb is still there after amputation.
Exactly.
That is genuinely surprising. It makes the symptoms feel less like a mystery and more like a specific kind of brain error in the prediction system. But if it's a prediction error, why does it happen to some people and not others? Is it simply caused by stress? That's a crucial point to clarify. It is not just stress, although stress can be a factor for some people, just as it can influence many physical health conditions.
Yeah.
FND is typically a much more complicated picture, arising from a combination of interacting factors.
What are some of those factors, then?
Previous trauma, both in childhood and adulthood, is a known risk factor. Research shows people with FND are at higher risk of having experienced trauma.
Right.
However, and this is very important, trauma is sadly common, and the vast majority of people who experience trauma do not develop FND.
That's a key distinction. It really is.
Think of it more like smoking and stroke. Smoking increases your risk of a stroke, but it's not the only cause, and not everyone who smokes has one. Trauma might perhaps make the brain more vulnerable to developing these prediction errors or disconnections.
Okay, so trauma is a risk factor that increases vulnerability, not a direct sole cause. What else?
Other medical or neurological conditions can act as triggers. Things like epilepsy, migraines, MS, or even an acute panic attack.
Okay.
Interestingly, seemingly minor physical injuries are also quite potent triggers.
Minor injuries, like spraining an ankle or developing carpal tunnel.
Exactly. Even a small injury to a limb can change the way the brain represents and controls that limb.
Uh-huh.
The symptoms, like weakness or tremor, might persist long after the physical tissue has completely healed because the brain's software for that limb is still stuck in an injured pattern.
That really aligns with the idea that the problem isn't the physical part, but the brain's command.
Right. And there's also ongoing research looking into potential roles for genetic factors and certain endocrine or autoimmune issues contributing to this complex vulnerability.
Okay.
And FND very commonly co-occurs with other conditions.
Such as what kind of things?
Anxiety and depression are common, although importantly, many people with FND do not have them.
Right.
Chronic pain is also extremely common alongside FND, though pain itself isn't currently classified as an FND symptom according to official definitions. Fatigue, autism spectrum disorder, ADHD, joint hypermobility, like being double jointed.
Really? Hypermobility.
Yes, that connection is being increasingly recognized. And also autonomic dysfunction symptoms, like problems with blood pressure regulation causing dizziness, are frequently seen.
You mentioned migraine as a trigger earlier. Is there a deeper, specific link being explored between FND and migraine?
Yes, this was highlighted in one of the sources, particularly by Dr. Staub's work. Migraine is incredibly common in the general population, right?
Yeah, very.
And FND is also far more common than previously recognized, so some co-occurrence would be expected just by chance.
But it seems like there's more to it.
Probably, yeah. There are a few key hypotheses. One is that some symptoms currently categorized as FND could actually be an as yet undefined subtype of migraine itself, just another way a migraine attack can manifest beyond headache.
So the FND symptom is part of the migraine experience in that case,
Possibly.
potentially. Another idea is that a migraine attack, because of the physiological stress and changes it causes in the brain, acts as a direct trigger for distinct FND symptoms to appear. So the migraine event pushes the brain into that FND pattern.
Kind of sets it off, yeah. And a third hypothesis is that some individuals have a shared underlying vulnerability, perhaps related to how their nervous system processes sensory information or handles prediction that makes them susceptible to both migraine attacks and FND symptoms,
Okay.
triggered by common factors like stress, poor sleep, or illness.
And sometimes an FND symptom triggered by a migraine might then become a persistent problem, happening even when there's no migraine headache.
Yes, that's also thought to be possible. The brain pattern, once established, can kind of take on a life of its own.
It really is a complex puzzle, and the symptoms themselves can be so varied and, you mentioned, fluctuate quite a bit.
They certainly can. FND can show up as motor symptoms like weakness, tremor, or jerky movements. There are those functional seizures we discussed, or problems with balance and dizziness.
Right.
People can experience sensory issues like altered sensation or pain. Cognitive symptoms like memory problems or feeling spaced out, zoning out, are also common.
Zoning out, yeah.
And then there are things like functional dystonia causing those dramatic postures or speech problems. Quite a range.
And I know a really harmful misconception is that if symptoms change, if they're bad one day and better the next, or even vary within a day, that means it's not real, or it's psychosomatic in that dismissive sense.
Oh, absolutely.
Yeah.
This is a deeply ingrained misunderstanding, and it's simply false. Many well-established medical conditions have symptoms that fluctuate. Think of MS, migraine, or even arthritis.
Good point.
In FND, symptoms frequently vary hour to hour or day to day. Someone might be completely disabled in the morning but functioning relatively well later in the day, or vice versa.
Right.
This variability can actually be a positive clue pointing towards FND, and not away from it.
So fluctuation is not a sign it's not real. It's actually part of the picture for FND.
Absolutely not sign it's not real. And using the word psychosomatic to dismiss fluctuating FND symptoms is based on a misunderstanding of both the term, which means involving both mind and body, and the genuine neurological basis of FND. It's not imagined.
Okay, so it's a real complex disorder of brain function, diagnosed by positive signs, linked to prediction errors and complex causes, and the symptoms can vary. This sounds challenging, but you mentioned there's real hope for recovery.
Yes, and this is the incredibly positive message. FND is potentially treatable, and recovery, even complete recovery, is absolutely possible for many people,
That's huge.
though outcomes vary depending on many factors, including access to appropriate care. It's vital for anyone with FND not to lose hope, no matter how long they've had symptoms.
Where does recovery begin? What's the first step?
Knowledge is foundational. Getting an accurate diagnosis and understanding what FND is, that it's a real treatable problem with brain function, is a crucial first step. It provides a platform to move forward.
Mm-hmm.
Resources like the neurosymptoms.org website and app mentioned in the sources are excellent places for reliable information.
You can't just give someone a website and expect them to get better from a disabling condition, right?
Exactly. As one source highlighted, for a disabling condition, a website link alone is not treatment. It's a starting point, maybe, but not the solution.
What is the predominant treatment approach then?
It's rehabilitation, but specifically tailored for FND. The goal is to help the brain essentially retrain or reprogram those faulty movement or sensory patterns.
Okay.
It's often multidisciplinary, meaning it involves a team, typically physiotherapists, occupational therapists, and psychological therapists like those using CBT.
And this rehab is different from, say, stroke rehab because the underlying problem is different.
Often significantly different, yeah. It needs to be targeted to the specific functional symptoms and address the underlying mechanisms we've discussed, like prediction errors, attention issues, or accessing automatic movements.
Can you give us an example of what functional physiotherapy might involve? Something concrete?
Sure. Think about Miranda's story from the sources. She had a functional gait disorder. She couldn't walk properly, but she could remarkably run.
Run, but not walk.
Yeah. So her physical therapist used running, which is a highly automatic motor program for the brain, as part of the treatment to help her access more normal movement patterns.
Clever.
She also found her walking improved when she was distracted, like being deeply engaged in conversation.
Ah, so it's about bypassing the stuck voluntary control by engaging the brain's automatic systems.
Precisely. It's similar to how you learn complex physical skills like skating or skiing.
Mm-hmm.
Initially, you have to consciously think about every little movement.
Yeah, very clumsy at first.
Right. But with practice, it becomes automatic, fluid, and requires less conscious effort. FND rehab often helps people regain access to those automatic subconscious motor programs that have become disrupted.
Makes sense. In psychological therapy, how does talking help with what seems like a brain function issue?
Well, psychological approaches are incredibly valuable and work on multiple levels. They can help individuals understand and manage the complex web of contributing factors in their life. Talking therapies themselves can influence brain function by helping people change their reactions, perceptions, and coping styles. CBT, in particular, has strong evidence for treating functional seizures, dissociative seizures.
Like the CODES trial findings you mentioned?
Yes. That trial showed that while CBT didn't always drastically reduce the sheer number of functional seizures, it led to significant improvements in patients' overall health, daily functioning, and satisfaction with their lives.
So quality of life improved even if seizure count didn't plummet.
Exactly. The psychological approaches can also address trauma history if it's relevant for a patient, but it's absolutely not necessary or appropriate for everyone with FND. It has to be tailored.
Are there specific behavioral techniques people can use themselves, like day-to-day strategies?
Absolutely. And many relate directly back to that idea of brain prediction and attention. Over-focusing on a symptom can actually make it worse, essentially turning up the volume.
Right.
Learning to redirect attention can be powerful. For zoning out or dissociative symptoms, actively trying to zone in by focusing intensely on a simple physical sensation, like drawing on your thumb with your finger, can help pull you back. Doing this early in an episode is key.
Like interrupting the pattern before it takes hold.
Exactly. For tremor, a technique called habit reversal or competitive inhibition might involve making deliberate, smooth, graceful movements with the affected limb, essentially trying to replace the tremor pattern with a more normal movement pattern, ideally when the tremor is starting.
Interesting. What about managing pain, which you said is so common?
Yeah, chronic pain is a huge issue for many people with FND. Understanding pain not just as tissue damage, but as something where the nervous system's volume knob for pain signals might be turned up, sometimes called nosoplastic pain, can be a helpful concept for management.
So the pain is real, but the system is amplifying it.
That's the idea. It's real pain, but the brain's processing is amplifying it. Management often involves strategies used for other chronic pain conditions, focusing on function and quality of life.
It sounds like having a supportive relationship with clinicians is really, really important throughout this process.
Critically important. The therapeutic alliance, feeling truly heard, believed, and respected by clinicians who approach you with empathy and genuine care, is fundamental to recovery.
Yeah.
Patients should never be made to feel that their symptoms are their fault. Discussing the possibility of symptom relapse and how to manage it is also part of empowering self-management. It's a journey.
So while there's a lot of progress, challenges definitely remain. Access and understanding.
Yes, for sure. The landscape is evolving. FND is increasingly being included in medical training curricula, research is growing, and care pathways are developing in some regions, which is great.
And patient-led organizations are really driving a lot of that change, aren't they?
Absolutely vital. Patient advocacy groups are essential partners with health professionals, pushing for better understanding, access to care, and providing invaluable peer support and information.
Yeah.
The FND portal essay, reflecting on a delayed diagnosis through the lens of history and science, is a powerful example of personal experience driving change and understanding.
But getting access to specialist care or knowledgeable clinicians can still be a huge barrier for many people, I imagine.
Oh, definitely. Specialist FND clinics are still limited, waiting lists can be long, and sadly, people still encounter dismissive attitudes from some health professionals. Changing long-held beliefs and practices in established medical systems takes time.
It does. What about the future? What exciting areas of research are happening? What should we keep an eye on?
Lots of exciting things are being explored. Researchers are looking at whether specific patterns might show up on brain scans that could help diagnose FND.
Objective markers.
Potentially. They're investigating digital treatments,
Ah.
exploring brain stimulation techniques like TMS, and even using virtual reality to see if it can help rewire those faulty brain predictions.
Wow, VR.
Yeah, altering perception and prediction. There's work on genetics, deeper dives into the full brain-mind-body connection through things like interoception, our internal body sense, and continued research into the links with comorbidities like ASD and joint hypermobility.
It sounds like a field that's finally getting the attention and scientific rigor it deserves after being misunderstood for so long.
It really is. It's a complex condition, but understanding it is unlocking better ways to diagnose and treat it, offering hope to millions.
Well, we've covered so much ground today. We've seen how FND is a real common complex disorder of brain function, not structure. We've navigated its difficult history and the crucial shift to a diagnosis of inclusion based on positive physical signs. We've explored the fascinating role of the brain's predictive power, the complex web of risk factors and comorbidities, the intriguing links to conditions like migraine, and the real potential for recovery through targeted multidisciplinary rehabilitation aimed at retraining the brain.
And perhaps most importantly, we've reinforced that FND is absolutely not imaginary, it's not faking, and symptom fluctuations are a feature, not a sign it's not real. That message is key.
So here's something to leave you with, a thought to carry forward. Perhaps consider for a moment the incredible, complex dance happening inside your own skull right now. Your brain's constantly making predictions to shape your reality, guiding your movements, your sensations, your very experience.
It's quite amazing when you think about it.
It really is. And conditions like FND, while challenging, offer a unique and profound window into understanding that astonishing process more deeply. They show us the intricate link between brain, mind, and body in ways we're only just beginning to fully grasp.
If this deep dive has sparked your curiosity, we genuinely encourage you to explore some of the reliable resources mentioned, particularly the neurosymptoms.org website and app, to learn more directly from experts and those with lived experience.
Thank you for joining us for this deep dive.